All right, so a lot of this we already talked about. So what are we going to do for the respiratory system? If we know that they might have some diaphragmatic breathing, if we know that they're at risk for respiratory insufficiency, what are things we're going to monitor? Respiratory things, right? Breath sounds. ABGs, because it's going to tell us if we're going to have a respiratory alkalosis or acidosis. And then that's going to tell us if our patient's crashing or that they're not, if they're getting if they're taking nice, deep, big breath sounds. It's going to tell us their breathing, what's their breathing pattern. Are they having respirations of 12 to 14 or are they having a respiratory rate of 30? Is that going to clue me in that, oh crap, I maybe need to check an ABG on this patient. Maybe I need to listen to breath sounds. Do they have any breath sounds in the lower lobes? What's their color of their sputum? Right? Because they're at risk for this pneumonia because they don't have a great cough. They're not taking big, deep breaths. So what are things that we can do to help them? Treat them. CPT, right? When pain management. Teach them how to cough. That augmented coughing that you learned during CP, during level 3. Anybody remember it from that long ago? Where you hold them and, kind of teach them how to push up or teach their caregivers how to augment cough. It's okay, don't look blank. It's just teaching them effective coughing. Suctioning them, using an incentive spirometer. And again, patient teaching family is going to be super important because is my patient with the C4 injury going to be able to help themselves augment? Do you need help coughing, Jordan? All right. So, is that patient with the C4 injury going to be able to do that themselves? No. Their caregivers are. And where are 90% of these patients? Home with their families. So are we going to teach the family, hey, if you notice their respiratory rate real high, if you notice that their sputum has changed, that you need to contact your healthcare provider right away because they're at risk for this? Or let's say you get a question that says, what is going to be the nursing priority? How do you know treatment's effective? What is going to be a good treatment for you to use with your patient with respiratory insufficiency? Okay, cardiovascular. If they're bradycardic, what are we going to give them? Atropine. So, if their heart rate's less than 40, we give them medicines. Again, we're going to teach family members, we're going to teach caregivers to look for these things. Sometimes these patients require pacemakers to keep their heart rate up. We talked about this. If they're vasodilating, if they're hypotensive, they need fluids. If we can't get enough fluids by mouth, or if they're having significant symptoms, then we're going to be giving IV fluids. We may need to give vasopressors, like dopamine. What do vasopressors do? Constrict, right? So that's what we're supposed to be happening with the SNS, but that SNS isn't working. It's not getting through. So we're vasodilating, so we have to kind of be the SNS for them. So we do it by giving drugs like vasopressors, like dopamine, to cause that vasoconstriction so they're not hypotensive. How are we going to know that they're doing okay cardiovascular-wise? Yeah, vital signs, right? Hemoglobin, hematocrit. If they're super low. You cheater. All right, and no, what kind of maneuvers lower your heart rate or blood pressure? Valsalva, right? Vagal, anything that vagals. Because normally, when we vagal, we drop that heart rate. So are we going to want to drop that heart rate anymore for this patient who's already got a heart rate of 20? or 30, we're going to send them into cardiac arrest. So anything, turning them, suctioning them, bearing down, we have to be really careful with these patients. But then again, you're like, oh crap, I've got my patient who needs to be suctioned because they're going to develop respiratory insufficiency and they're not coughing up secretions well. So it's a balancing game that you guys are playing a lot. So you're going to want to make sure, maybe before I suction my patient, I go take a heart rate and make sure that it's normal. Because if they vagal a little bit, they're not going to compensate like you or I would. They're going to decompensate, and then they're going to have a hard time coming back up. So maybe I'm going to make sure that I have atropine on my MAR, or that I'm going to go ahead or make sure that my patient's on dopamine before I really start getting very aggressive with my suctioning. Or that maybe as the nurse, I'm going to be proactive, and I know that my patient's admitted for pneumonia, and I'm going to have to be suctioning a lot, and they have a spinal cord injury, so I'm going to make sure the doc knows that I'm going to need these things on hand if I don't have them. All right, urinary systems, sorry. So, if they're at risk for urinary retention, if they're at risk for that autonomic dysreflexia, UTI, we're going to cath them. And we want it to be intermittent as much as possible because we want to prevent infection. They need to be cathed every 3 or 4 hours. We're going to monitor for any signs or symptoms of infection. Everybody knows what those are. We don't need to get real in depth, right? We've made it to level 4. Chills, malaise, fever. Aseptic technique is really important. Again, patient, caregiver, family teaching. This is hard. A lot of these patients, we talked about the high cost of this. Do you think that there are patients out there that are reusing the same catheter 20 times? Yes, a lot. It's really sad. They don't have access. This is a huge cost to them. Their insurance will only cover so much. So you have to try to teach these families and work with them the best you can. So if you know a family has that situation and a family comes in with a, patient comes in with a fever and you ask them about how often they're cathing, maybe you should ask them, do you use new equipment every time you cath? Check the patency. Lots of fluids to make sure they're staying hydrated. Patency of like the catheters. I have 2 kids, y'all. So I do. I often have to hear what they're doing across the room, and you got to pick that up. So if you have a question, just ask it because I'm probably going to hear it anyways. Right, Damien? Darian, I'm sorry. All right. So neurogenic bladder. A lot of times you use anticholinergic drugs like ditropan. This helps with those contractions. We use the alpha adrenergic blockers to help relax smooth muscle. Again, prevents the contractions and the pain. Antispasmodics. And sometimes they get a urinary diversion surgery. This is a really cool surgery. They basically just take the ureter and make a little stoma on the skin, and the patient can cath themselves. So really good for female patients that it might be a little awkward. But those who have good function of their arms, again, our goal is to provide them as much control and as much normalcy as they can, right? So if they can be in control of cathing themselves and don't have to rely on someone else, don't you think that provides a lot of dignity and respect and control for them? For me, it would. Alpha. That's a little alpha sign. Adrenergic, blockers, relaxes smooth muscle. It's really important that we make sure we get good referrals and supplies. Sorry. When I did this, I didn't, on mine, it doesn't have this. But I guess when I do it as a presentation, they want to make sure they get credit. So on my paper, it doesn't have that. Referral supplies. So we want to make sure, like I said, a lot of these patients don't have access. Maybe are embarrassed, don't realize that they, maybe they don't know they need more supplies or whatever. It's our job to get them as much access and help as we can. All right, and G-tube, are we going to keep feeding patients that have a paralytic ileus? Nope. We're going to throw an NG tube down. So how are we going to know they have an ileus? Listen to the bowel sounds. As silly as that sounds, that's why we spend so much time in level 1 making you do that head-to-toe assessment. It really is kind of important. I know it seems crazy, but when we want to listen to that belly. If we don't hear bowel sounds in our spinal cord injury, then we're going to say to the doc, hey, I'm concerned. I don't hear bowel sounds. They haven't had a bowel movement. I'm going to stop the feeds until I know for sure they don't have an ileus, because I'm not going to keep feeding that person until they, one, throw up and aspirate, because they already have respiratory insufficiency. They're already at risk for pneumonia. I'm going to go ahead and call the doc. So again, could a nursing question be, you walk into shift on your spinal cord patient, you listen to their stomach, there's no bowel sounds. What's a priority action? 1, stop feeding. 2, say have a great day. 3, increase feeds by 30. They're hungry. Okay, so it's going to be to know, and it's not going to be that obvious, obviously, but it's going to be to know, okay, wait, I may need to stop my feeds. They may have an ileus. I need to follow up with the doc, because I don't want to do any more harm. I don't want to make them die, right? Don't make your patients die, y'all. Reglan. Reglan does what? Yeah, it gets things going. Right? So if we have hypomobility, this gets it going. Does it? Yeah. Stress ulcers, we learned about this in level 3 when we talked about adult nutrition. We're going to use, if they have high hydrochloric acid, we want to use things that are going to decrease hydrochloric acid. PPIs, H2 blockers. If they're at risk for bleeding, what are things we're going to monitor? They're bleeding out in their stomach. Okay, hemoglobin, hematocrit, yeah. What is one thing you're going to be doing as the nurse? Several times a day? No. Assessing how? Intake and output, but vital signs, right? Something as simple, blood pressure. What's going to happen to their blood pressure if they're bleeding out? It's going to decrease, right? So, again, these simple things that we take for granted. You guys are like, I did vital signs and assessments in level 1. No, they're your hallmarks for all these big things. So I get a blood pressure and your tech comes and tells you, oh, your spinal cord injury, oh yeah, their blood pressure dropped, but no big deal, and walks away. A red flag might be going off in my head to say, let me see what the last H&H was. Let me go ahead and check the abdominal girth, because, oh, could it be up a little bit? Let me see what else could be going on. Could it just be that they just had a little bit of low blood pressure? Yeah. But you're to use these signs, and you use the vital signs. You use your assessments as triggers to follow up, do more care, look at more labs, put the puzzle pieces together. We talked about constipation. I'm going to put it all here so you guys can do it. They really need to be on a good bowel program. A lot of times we use rectal stimulants, suppositories like glycerin. We do lots of fluids, lots of fiber, and a stool softener. And we try to get them on some kind of regimen. Just like when you were training, like I don't know if y'all who have kids did this, when they were 3 and you were training them how to go potty, we went to the potty every day. We sat on the potty for 10 minutes. We read our book and we got an M&M when we were done. So, all right, maybe they got an M&M, maybe you don't, but you do the same kind of regimen with them every single time. They go at the same time. They go sit on the toilet for 2 times a day, 3 times a day, whatever it is. Because again, the neurogenic bladder, the neurogenic bowel, they're going to be big causes of what did we talk about? What big complication? The autonomic dysreflexia, right? We want to be careful with laxatives. We don't want to use those regularly. That's what this says. Oral laxative, don't use regularly. They can cause electrolyte disturbances. They can become dependent on them. They can have some rebound. So we don't want to use them regularly.
Since the oral laxative is like a stimulant, could that be like could that stimulate them to have like that autonomic dyslexia too? I mean, since it would cause kind of.
No, it's not that kind of stimulant. I get what you're saying, but no. Mm-mm.
Okay.
No, I get what you're saying, but no, it's not going to stimulate it in that sense.
Okay.
All right, so skin breakdown, we've done this. We're going to look at the skin, examine it at least every day, especially the bony areas. For you guys, every shift. But for your caregivers, family members, they need to look at that butt. They need to look at those heels. They need to be repositioned. They get special mattresses, chair cushions. Nutrition is really important for them, especially protein. Also albumin. And we want to really be careful, protect them against any thermal injuries. Remember, they can't feel. So if they get splashed with hot water, if their caregiver is a smoker, they have to be careful because if they drop a cigarette or do anything like that, they're at really high risk of getting a bad burn. My favorite word that I can't say, poikiothermalism. So we need to monitor their environment. We need to be really careful about keeping rooms too cold or too hot because they're not going to be able, if you don't notice their thermostat or a caregiver goes off for the day and doesn't realize the AC is broken, for instance, and that patient's sitting there all day, they're not going to notice that the AC is broken. Would we notice in a hot second? As my husband likes to joke, I have 1 degree of like comfort, so I would notice, but they don't notice it. So they really need to monitor their environment. Monitor their body temperature regularly. They're going to take their temperature frequently. Be careful about overloading them with blankets, or like when you're giving them a bath. You don't want to just strip them, take the towel off and just be giving them a bath. You want to keep parts covered. Be careful with that. Oops, sorry. Don't freak. Metabolic, again, be careful with suctioning too much. Monitor their fluid and electrolytes. Again, high protein diet. Make sure they're getting enough calories. They may need to have an evaluation of their swallowing, depending on where the injury is. If it's a high-level injury like C4, be careful, because again, these patients are at risk for aspiration. So they may need to thicken their liquids. They may not be able to eat certain foods. The best way to feed a patient is by mouth, right? If we can't feed them by mouth, then we start with something like an NG or G tube. If we can't use an NG or G tube because of like a paralytic ileus, then we're going to give them TPN or PPN. Oftentimes they need supplements and lots of fiber. So if you didn't pull out that they need fluid, fiber, and protein from this lecture, I don't know what to tell y'all. Again, anorexia, address the reason. We talked about this a lot. They want to maintain some kind of control. So make a contract with them. Make it a good eating environment. Make it something enjoyable for them. Have the patient be responsible for recording, calorie counting. Give them some control over it, but making sure they're eating enough. DVTs, we've got this, right? SCDs. Range of motion, get them moving. If they're at risk because of because blood is pooling, then we want to get the blood going, right? Get PT involved, get OT involved. If you don't see that that's ordered for your spinal cord injury patient, I'd be putting a request in as the nurse. They're oftentimes on heparin or Lovenox. And it's really important that you as the nurse, again, because they're not feeling anything, right? So your cardiac patient might be able to tell you, I've got some pain in my calf, or I've noticed some warmth in my calf. Can your patient with spinal cord injury tell you that? No. So again, teaching your caregivers, teaching the patients, teaching their families, and you as yourself as the nurse, you're going to do a good assessment. I mean, be honest with yourselves. I'm not going to make you raise your hands and point yourselves out. How many of you, if your patient is sleeping in the morning, pull down the blankets and look at their legs? I would say that some of you are probably guilty of that. I'm guilty of it, of sometimes not wanting to bother the patient. But that's really important that we go ahead and we get a full assessment, especially the lower extremities, noticing any deep red color or any warmth, any edema, because that's going to be a good sign that there might be a DVT. That can lead to the pulmonary embolism, which is one of their leading causes of death. All right, so instability, we want to prevent any further injury. That's our main goal. So we want to properly immobilize, either with traction, with braces. Make sure when we're turning them that we're log rolling them. The book goes into kinetic therapy. You guys don't have to get in depth. Bless you. If I'm going too fast, y'all, just slow me down. Spasms, we use baclofen. Contractures, range of motion. Again, they're not moving around a lot, right? So if they're always kept in this position, the muscle's going to shorten. We want to make sure that we get physical therapy involved, that we get occupational therapy involved, that we teach family members. Is it easy for these patients to give up, especially with a higher level injury? All right, so sexuality, make sure we educate them. Alternative methods. So if they have issues with erectile dysfunction, there are other ways they can be sexually active. If you want to read about it, read it in your book. If you don't know them already. Medicines can help, Viagra. There's also vacuum devices, surgical procedures.
Can you please explain?
I would address your book. All right, women, you want to make sure you teach about birth control. Teach them about lubricants so they don't get any tears or injury. They have to actually, if they do get pregnant, they have to be careful because they can't feel contractions. So, and I mean, I know, Aricia's like, holla. It's actually kind of scary because they cannot feel that birth is about to start. So literally a baby will just pop out of them. So if they go into early labor or preterm labor, they literally could just like birth their baby because they don't feel that it's happening. So trust me, I felt it when it was going to happen. So they don't feel it though. So they have to be careful because if they deliver spontaneously at home or whatever, they get more careful monitoring, especially towards the end of their pregnancy. And the important thing is to use medical terms with patients. Try to be more mature than I am. Yes, don't tell them there's a brochure, read it. It's a big part of their lives. I mean, it's a big part of people's lives, but people don't want to talk about it. They do get embarrassed. So, but it is something that they want to know about and have questions about, and we need to give them some answers. All right, psychosocial, maintain hope as much as possible. Allow for mourning. They're angry. They are sad, they are mad, they are pissed off, they feel hopeless. I mean, all those things. If I got an injury right now and I couldn't do my races or come up here and teach you guys or do the things that I love to do, I would be angry at the world. I think a lot of people would be. If all of a sudden their lives were just changed and there is no getting that life back. So let them be angry. Let them be pissed off. Sympathy is not helpful. Don't tell them it's going to be okay, because it's not. Allow for them to have those outbursts. Allow them to be angry, but still maintain some hope. And that's hard. That's really hard to do. They need to be involved in counseling. Sometimes they need, antidepressants. They need support groups. They need other people that have gone through this. Because you telling them you're walking, talking, they're not going to get a whole lot of sympathy from you because you are walking and talking. They want to relate to someone. I know when my mom passed away, the people closest to me who still had their moms, I hated them. And I felt guilty that I hated them. And that's a strong word. Aricia is looking at me like, oh, crap. But I was angry that they still had their moms. I was angry that they still got time with them and I didn't anymore. So it was hard for my best friend, who I've known since I was 16 years old, for like a really, really long time, to talk to her because she would still get to go talk to her mom. But this random coworker that I had never talked to before, who lost her mom just a year or two before, we became really close friends because she could relate to how I was feeling. That's how they feel. And then because you don't want to feel guilty about the way you're feeling. So they're mad and angry that you can still walk, but they don't want you to not walk, but they just don't want to discuss with you. Does that make sense? All right, so that's why support groups, that's why counseling is so important for them. Because as much as you can have sympathy for them, they don't want you to feel sorry for them. They're angry enough, they're feeling sorry enough for themselves. All right, don't go rushing to like write this all down. If you want to come back to it, you can. I'm just going to go through it fast. These are just some nursing diagnoses. If you get a patient, they have ineffective breathing pattern because of muscle fatigue, because of paralysis, because of retained secretions. They have impaired skin integrity because they're not moving, because they have poor tissue perfusion, right? They have impaired urinary elimination. They have constipation related to the neurogenic bowel, related to the decreased fluid intake. It's all the stuff we've been talking about, why we need to do all these things. They're at risk for the autonomic dysreflexia because of that stimulation of the sympathetic nervous system. So what's our goals? Prevent further injury. So we want optimal level of neurofunctioning. That's why we want to prevent further injury. Our goal is that they will have the best level of neurofunctioning they can possibly have. We want minimal to no complications of this immobility. We want them to learn skills, gain knowledge, and acquire behaviors for care of self. We want their input. We want to know how we can take care of them. We want to return them to their home and their community as much as possible. Maybe they can't go back into construction building things, but maybe they can be in the management side of construction. They still have a lot of valuable input. Just because they can't do things physically doesn't mean that they can't help out mentally somehow. They still can be contributing members to society. They just have to adjust. Oh. Rehab and home care, obviously it's complex, lifelong. Again, the goal is to function at the highest level possible. It takes a whole team. So, like we talked about, physical therapy, occupational therapy, the physician, you guys. And it's all organized around the patient's goals. What does the patient want? How much care do they need or want? What do they want to be involved in? What is important to you may not be important to them. And what's important to them may not be important to you, but it's not what we want, it's what they want. It's like when we talked about hospice and the lady was talking about, you know, the two different goals, like someone doesn't want to be alive if they can't take care of themselves, and somebody else doesn't mind if everybody takes care of themselves as long as they get to see their grandchild every day. Same thing. What does this patient want? Patient's expected to be involved, though. Frequent encouragement. I feel like these are like goals for you guys for nursing school. Organized around students, goals and needs, but you're expected to be involved. I must encourage you frequently. You're doing great. All right, an evaluation. How do we know that they've done well? Well, they're ventilating good, right? They have intact skin. They have good bowel management. They have no autonomic dysreflexia. They have no complications of immobility. I mean, we can keep going on and on and on. How do we know we've done our job? Because none of that bad stuff happened. Or we prevented it. All right. That's pretty much it. Does anyone have any questions? All right. I do have a, Desiree, sit just 1 minute. I know, I'm sorry. I do have cahoots for this, which I was going to do, but because I know everybody wants to go out and see the peak or whatever, we'll go and do that. I'm working with IT to set up doing cahoots online so that I'm trying to get a live webinar set so that you guys could do it from home and we can get interactive. So, so I'm working on it. But if not, we might do some tomorrow when class is done, okay? All right. All right, bye guys. Have a good day.